Okay, we're going to do the knee joint now, and we're going to deliver it actually to two sections. We're going to do the subjective and the objective. Now, the reason we do the subjective is for two clear reasons. Firstly, the patient normally can tell us exactly what the diagnosis is. They can tell us what the problem actually is just from the kind of questions you ask and the answers you get back. And secondly, debate still remains over many of the orthopaedic and manual tests when it comes to the knee joint. Therefore, to help mitigate this, we do a good, thorough, if possible, subjective exam. So, subjectively, what do we ask? Well, the first thing I do ask is, has the patient got any problems with their lower back, any problems on their hip? Because we're looking for any potential referred pain. Now, we have to remember that knee joint pain may have something to do with the back stroke hip, but it may not be referred by the back hip. So they may be two separate pathologies because there could be some biomechanical issues. So please, just because they say, well, I've got this back pain, you go straight for the back pain, assuming that that back is definitely causing the knee. It may not be. There may be two separate pathologies, so examine both regions. The next thing I do is I ask about age, or I read the notes in different ways, but I do like to ask the patient myself, just in case my notes are wrong. So generally, in the over 40s, we can sometimes assume that it's more likely to be some form of degenerative problem within the knee joint, whether that be osteoarthritis of the tibiofemoral joint, osteoarthritis of the patellofemoral joint, but some sort of degeneration. The other thing it could be is a tendinopathy, in particular a patella tendinopathy stroke tendinosis. Ligament strains of the knee joint are rare, and the reason they're rare at the age of 40s is because as the knee gets older, we lose elastin from many of the ligaments and actually some of the tendons as well. And because of this lack of elastin and lack of water, because we dehydrate as we get older, they become more fibrous. And as they become more fibrous, they become more thickened. And as they become more thickened, they actually solidify the joint more. Now, I'm not saying you don't get ligament strains over this age group, but it's less common and you just need to take that into consideration. In the under 40 age group, it could be a whole host of different pathologies. It can be arthritic stroke degenerative changes, it can be a menisci pathology, whether that be degenerative or an acute tear or a handle tear or peripheral tear or central tear. It can be an ACL, it can be a PCL, it can be a bursitis, it could be an intrachondral defect, it could be a chondral defect, it could be patellofemoral osteoarthritis, it could be patellofemoral chondromalacia patella, instability, hypermobility, dysplasia. It could be almost anything. It could be tendinitis, patellotendinitis, jumpers, as well as Osgood. So it can be a whole host of different pathologies. So we need to have an open mind. Generally, under the age of 18, we tend to think more of, again, the traction hypophysitis pathology. So your Osgood's, which is classic. You get jumpers knee or your Hansen-Larsen syndrome, which is a tendinitis or slight avulsion of the patellar tendon or an inflammatory process of the patellar tendon as it comes away from the apex of the actual patella. And then we think of pathologies such as patellofemoral joint problems, in particular dysplasia, hypermobility, instability, which is common in children as they get older and can heighten during their growth spurts. The next thing we ask is exactly where is the knee pain location. Now the location gives you an idea of where the pathology actually is. So if they point to the medial side, we would consider medial collateral ligament. We may consider medial tibiofemoral joint osteoarthritis, stroke menisci, or even superior medial, we think maybe medial patellofemoral joints. On the lateral side, we think about the LCL, we think about lateral menisci, we think about lateral osteoarthritis, but we'll also consider ITB. We'll also consider PCL, as PCL can cause posterolateral instability, leading to lateral knee pain. And the other thing that we could consider is any other air capsule on the lateral side can also be a problem if there is this posterolateral instability in the absence of lateral menisci tear or in the absence of a lateral menisci tear, which can also cause instability. So lateral side, arguably, is probably more pathologies it could be than the medial side, even though the medial side is probably more common for knee pain generally. Posteriorly, we think about intra-articular. We think PCL, we talk about ACL, we talk about menisci, we talk about osteoarthritis. There is a bursa at the back of the knee that we need to be aware of. There are also some lymph glands at the back of the knee we need to just be aware of. But it also could be muscular. Obviously, gastrocs, calf, and obviously the hamstring muscle. So it can be a muscular injury as well. And then anteriorly. Anteriorly normally denotes that there is some form of patellofemoral problem, whether that be patellofemoral osteoarthritis, degenerative changes, whether that be applied pathology, whether that be dysplasia, hypermobility instability, whether that be chondromalacia patella, whether that be chondral defect. So there's a whole host of different patellofemoral problems it can be. So all that location is doing is just defining and localizing what potentially could be the issue. The next question arises mechanism of injury. Now, for two reasons. Firstly, if there is a clear rotational injury, it may indicate again some form of cruciate ligament, maybe some form of menisci. There's a genuine, common cause which could be triggering that off. But if there is no mechanism of injury, it's unlikely to be a muscular injury. It's unlikely to be a ligamentous injury. We know ligaments and muscles normally go with some form of mechanism of injury. So just by asking how do you think it happened gives us a good idea of what's going on. Aggravating easing factors, again, in the absence of aggravating easing factors, we may be thinking something non-mechanical in origin. Chronicity is another question I tend to ask. If they've had it for a long time, more than say 4 or 5 months, it's unusual to have a grade 1 stroke, grade 2 MCL injury, LCL injury at that. It's unusual to have a muscular problem for that long. So again, it gives me an indication, well, I can exclude those type of things if it goes on for a long period of time. Family history is something that I always ask when it comes to knee joint, because there normally is a family history of knee problems if they've had it there for some time, such as osteoarthritis, biomechanical problems, in particular dysplasia, hypermobility and instability. If there's a family history of it, this patient may have it as well. I ask them also about childhood knee pain, because we know for a fact that patellofemoral pain during childhood can manifest itself as degenerative changes as they get older. Research is shown this numerous times. So again, getting an idea of their background, where they've come from, and their childhood development can give an indication what potentially could be the problem in knee. I ask about the 24-hour pattern. If they wake up with morning pain, stiffness, and it gets easier, that obviously indicates some form of degenerative problem. If it gets more sore throughout the day, that could be biomechanical, that could be shoe wear as an example, but it also could be, again, a bit of wear and tear of the ligament. So we just need to be observant of that 24-hour pattern. And again, sometimes I say, okay, so what was it like yesterday? What was it like the day beforehand? What was it like the weekend? And if they're not sure, then say, okay, just keep a diary over the next 1 week and let me know by next week a pattern, because sometimes what they do at weekend is different from what they do during the weekdays, and you can break down what potentially is the cause by understanding what their lifestyle was like and how that relates to their pain. Because if you don't get this, not only can this give you a clue to what the problem is, but you'll get the problem right, and then because you haven't addressed the cause, it may trigger off again. So that's why I asked that question for. Other joint aches and pains, again, just to rule out any biomechanical issues, and again, any rheumatic pathology. Past medical history is also important. Have done any previous surgery, either on that knee or any joints in their lower limbs or even their upper limbs. Because again, if they've had surgery on one knee, sometimes they put more pressure on the other knee, that gives them fault. If they've had surgery on their foot, they've had surgery on their hip, even their back, it can tip that balance. And that balance could be causing the pressure in that particular pathological knee joint. Any lifestyle changes? Have you changed anything recently in terms of your shoe wear? Have you changed anything of your weight? Weight can be a really big predisposing factor for the knee joint, and it can be a sensitive question. I don't like asking if they've had any changes in their weight rather than have you gained weight, have any noticeable changes, but it can have a bearing, especially on arthritic knees, as an example. If they're sporty, have you changed any duration, intensity or frequency of your sport? Have you changed the course? Have you changed anything that may have triggered off this pain? So we kind of get an idea of what's going on. Has anything changed at work? As their seating position, I know it sounds really stupid, but a seating position in the car, if they've got more close to the car, really can increase the patellofemoral angle. So therefore there's more patellofemoral pressure, giving patellofemoral pain. Simple things like that can have a big influence. So we ask, we probe. Special and specific questions on the knee joint include given way on the knee, which may indicate some form of intra-articular body, some sort of bucket handle menisci tear, so peripheral tears and even central tears in this guy will not make the knee clunk or give way. But a big bucket handle tear where flappers come away, that can give way. Obviously, osteochondral defects and patellofemoral joint. If a patellofemoral joint clunks out, subluxes, it will cause a massive clunk. So we mustn't forget, it doesn't just mean tibiofemoral joint. Intra-articular pathology would indicate some form of osteochondral fracture, some form of dissecans, obviously a loose body, and also maybe a massive tear, an ACL tear, a bucket handle tear, which is a big tear and a flap to come away in the cartilage and patellofemoral. When it comes to clunking, again, we think about menisci, but we also think about patellofemoral joint as the patella subluxes away from the patella. And locking on knee, again, indicates maybe some sort of loose body inside osteochondral defect, but it also could be, again, a bucket handle tear, but also when a patella subluxes, the knee locks. It doesn't want to move anywhere due to reflex inhibition. So don't forget patellofemoral issues as well. Red flags when it comes to knee joint, not many, surprisingly. I would say bilateral numbness of the legs generally would be a red flag. I would say giving way or repeated giving way of both the knees may indicate some form of cord compression. I know for any colour changes or vascular changes of the lower leg, which may be vascular related or DVT related, and not for any extreme heat or hot, which may indicate maybe some form of infection stroke DVT. Now we're going to carry out an objective examination of the knee joint. Now you'll find that with this presentation I won't go for all the classic ones that you may have seen already, mainly because there is a question mark over the reliability of many of the orthopedic tests when it comes to the knee joint. Yes, we can do 3, 4, 5, 6, 7 tests on the knee joint, but not always are they going to be reliable depending on who does them. Hence why we do a comprehensive subjective to give us an indication of what could be going on, and then we carry that out and further that with some objective tests. So, objective exam wise, one of the first things I look for is just observation. Can I see any scars anywhere? Have they had any recent surgery on both the knees? Remember, if they've had surgery on the right knee and they get left knee pain, that could give us an indication. So we're looking for any obvious, any redness. I do feel the back of my hands on both legs, not just the knee joint, because again, some patients can get a DVT and they will just feel pain on the upper part. So we just need to get an indication. Is there anything which doesn't feel right or doesn't look right? Next thing I tend to do is joint line tenderness. This is one of the easiest things to do and really can tell me if there's a problem with the menisci of the joint. So, as an example, on Gerard here, we just bend his knee up to 90 degrees, which opens up the anterior portion of the tibiofemoral joint. And what I'm doing is here, I'm just palpating his joint line. I'm looking at him as well as I'm talking to him, just to make sure there's no tenderness or any feeling of sensitivity. Now, I will say in most people over a certain age group, they are quite sensitive over this area, but you always compare left to right to make sure there's no difference. But the other thing I'm doing is I'm feeling the joint as well, because in a degenerative knee, in an osteoarthritic knee, you will find that first of all there's a little bit of crepitus, which may indicate some osteophytic formation or degenerative changes, and I'm feeling for the closure of the joint line. The joint line should have a good 2-3 millimetre gap, approximately where the MCO is, as an example, or just where the LCO is. And if it's significantly closed down, again, it may indicate some degenerative changes. And again, I'd palpate this joint line, comparing this side to the other side to determine what's going on. And again, palpate and feel the gap between the medial side and lateral side. You'll find that most patients, the medial side is closed down more than the lateral side, mainly because a lot of people tend to pronate or walk on the inside part of their legs. So, palpation of the joint line is instrumental. And again, tenderness denotes the fact that it could be a menisci pathology. Now we'll do the odd classic McMurray's test. Now there are 7 versions of McMurray's test currently in literature which have been published. We're going to go through the very first one only because more research has been aimed at that one, certainly in the 60s, 70s and 80s, than all the rest of them. And this one has been shown to be quite sensitive and specific about the fact that intra-assessor reliability is questionable. Now, what we're looking for in McMurray's test is a clunk. Pain is not a positive indicator, and it would be a shudder. It would be a really big clunk if it was positive. Now, for the lateral menisci, we take the knee into flexion. We then take the leg, the tibia, into medial rotation. We then add some very slight ABD abduction, away towards me, and then go into full extension and holding that downwards. And what we're feeling for, I normally do that 3 times. 1, 2, and 3, and we'd notice any clunk. Now, if it was a medial menisci, it would be flexion, lateral rotation of the tibia, some slight ADD adduction, and in a slight valvular stress, we go into extension of the knee. So, flexion, lateral rotation of the tibia, some slight ADD adduction, some valvular stress, and then we go into full extension. And that was the original Murray's test that was done in the 1940s, actually. And you'll find that this test is quite sensitive, but again, we're looking for a significant clunk. And that clunk is a bucket handle tear, because this test will not be positive in the majority of patients that have just got some sort of peripheral tear, or vertical tear, or central tear. This needs to be a bucket handle flap, which has come away from the main body of this guy, and it's flapping in the condyle notch. That's why when you rotate and you go into extension, you are jarring into that condyle notch, which is causing the clunk sensation. Just be aware, in patients that tend to be hypermobile, you will get a false negative, because there is some instability within that knee. So just bear that in mind. And obviously I'll compare left to right. The next test we tend to do, which is probably another gold standard, is Lachman's test for instability. Now, I'm not going to say ACL or PCL, because what you've got to appreciate is, even though it's quite a sensitive test, it's not specific to ACL or PCL, because if someone again has got a massive bucket handle tear, or they've got a large tear inside their knee, or they've just got a massive capsular instability because they're hypermobile, you will get a false negative. So all this tells you, does the knee feel unstable mechanically compared to the other knee? And I say mechanically because, again, someone can have an intact ACL, maybe slightly overstretched or elongated, but very poor proprioception. So the knee will still kind of give on it, like the ankle. So we just need to be aware of that. So again, we bring the femur up to 30 degrees. And if you've got someone like Gerard who's got big thigh muscles, you may want to put your leg underneath to stabilise it, because that's quite a big chunk to grab hold of, or a towel underneath it. And then all we're doing here is you're translating the shin forwards and backwards like so. And we're feeling now, we're not looking for pain, we're just feeling to see whether that end feels firm, i.e. the cruciate, or the other structures are stopping it go, or does that feel quite empty? Does that feel really soft? And oh, I can take that a bit more. And we're always comparing again left to right. You will find there are variations in people. You will find gender variations. You will find age variations. So the more testing you do of this particular test, the better you become, more sense you come to. Yes, this feels normal. Actually, no, this doesn't feel normal. But remember, Lachman's is not specific to ACL, PCL. It just gives an idea of AP, translation, stroke instability. The next test I'm going to show you is a test basically for patellofemoral knee joint. Now, the general test that I find that tend to be more reliable is Clark's test and also patellofemoral groin test. And they're just for patellofemoral joint problems. It doesn't tell you what's going on inside the patellofemoral joint. It just gives you a generic potential pathology. So, with Clark's test, what we do is you get the web of your hand, like so. You place it on the superior border of the kneecap and you push down very slowly. Holding it there, you ask the patient then to press their knee down into the couch or underneath your hand. And if they get any wincing or any soreness, that may indicate some patellofemoral pressure, stroke inflammation. Now, that may indicate some form of chondral defect, that may be some form of plica, patellofemoral instability, hypermobility, some sort of biomechanical factor, but there is some form of college chondromalacia or degenerative disease. It could be any one of those, but all this is doing is just telling you exactly what it is. There is no orthopedic test, to my knowledge, which can definitively tell you exactly which one of those pathologies it is. The only reliable way really would be to scope it, and even an MRI scan, to an extent, cannot always tell exactly what's going on. The other test, patellofemoral groin test, is a little bit more challenging. And for this, what I'm going to do is I'm going to move the kneecap medial lateral. I'll place my thumb directly over the knee and I press down with some force. I'm watching the patient, and as I'm doing that, I'm gliding the kneecap medial lateral as I'm pressing down and watching his face. Now, there are two things. You're looking for any wincing, any discomfort, again, compared to the other side. But the other thing you're feeling for any crepitus, any noises coming from me. Does it feel congruent? Because what should be happening as you're going medial natural, it shouldn't just go like that. It should go in and then out, because obviously we've got the intervertebral groove of the sulcus there, and that kneecap sits nicely. So when I'm pressing down and moving it medial natural, it won't just glide, it should go in and out, in and out. Now if it goes straight across, it could be means they've got a shallow groove. And we know shallow groove condyles of the femur is related to hypermobility, but also patellofemoral knee pain generally. If it goes in and finds it very hard to come out, that means that groove is too deep. Again, that can cause patellofemoral inflammation, stroke pressure. So feel the joint, feel for noises, any crepitus, but also observe the patient as well. So it is quite a nice test, again, for patellofemoral issues, and I will do that in conjunction with the Clark's test. Palpation can be specific and sensitive, some structures, but again, intra-assessor reliability, how I do it, how someone else does it, all slightly different. So joint line tenderness, we said, I always palpate the joint line just to see if there's any tenderness, any crepitus, any osteophyte formation, and a closure of the joint line. I will also palpate the patellar tendon from the apex, where you would get a jumper's knee, as an example, straight down the tendon sheath into the tibial tuberosity. Pain at the tibial tuberosity again would be potentially Osgood's. At the apex would be jumper's knee, or where the tendon comes away from the patellar tendon. And within the patellar tendon itself, it will be sore. It will be sore if there's a tendonitis or a tendinosis. Now you could suggest, well, to confirm it's a tendonitis, just contract. So again, you'd ask them to lift up the leg and they had pain around this region, it could be a patellar tendonitis. But please appreciate, it could also be patellofemoral joint as well, because patellofemoral joint causes inflammation behind the knee, which gravitates down into this fat pad around the knee, which soaks up some of that inflammation. So that tenderness of the fat pad around that region, it could be fat pad impingement syndrome. However, it could also be a patellofemoral issue where that inflammation is sinking down and soaking up the inflammation from that fat pad and giving you that kind of pain. And when you contract the muscle, you add a bit more pressure in that area, it makes it more sore. So just be conscious that some of these tests aren't that specific, but they're giving an indication of what's going on. So you can see I haven't gone through that many tests compared to some other clips or other books you may have read, but remember there is a question mark on the reliability of many tests, hence why the subjective combined with the objective together work well in trying to give you some form of working diagnosis.